Good morning, everyone, and welcome to our weekly grand rounds. It's my pleasure this morning to introduce our three-person team. Let me make sure we're there. Okay, the title of the topic is the Weekly Rehabilitation and Pain Program, also called WRAPP. And I'll put this back here for anybody who still needs to enter the CME code. Our first speaker is going to be Dr. Paola Genovese. She's a PCH faculty member who's triple board certified. She's board certified by the American Board of Pediatrics as a general pediatrician. She also, by the ABMS, has a board certification in hospice and palliative care. And lastly, in the American Board of Pain Medicine, she has a board certification in pain medicine. She did her education and first residency in the country of Paraguay, then came to the United States and did a second residency at the Sinai Hospital of Baltimore in Baltimore, Maryland. And then she did a fellowship at Ohio State in hospice and palliative care, and another fellowship at Seattle Children's in pediatric pain medicine. So she's very well qualified to be our speaker this morning. In addition to that, she has advanced training in lymphatic drainage, lymphedema, as well as medical acupuncture from Harvard Medical School. Our second speaker is Dr. Zakaryan, who's a licensed clinical psychologist with clinical specialization in pediatric psychology and pain management. He received his doctorate degree from Loyola University in Chicago, completed his internship at Rush University Medical Center, and then a fellowship at Children's Hospital of Orange County. He's, in addition to speaking English very well, he's fluent in Spanish and Armenian. He joined Phoenix Children's in 2017, where he's a psychologist and as part of the pain management team, and is starting as a site director for the Comfortability Program. He also assists with the Division of Psychology Training as program director for the postdoctoral residency fellowship. Thirdly, we're going to have Dr. Rachelle CherryHolmes, who's a doctor of physical therapy. She's been a member of Phoenix Children's Outpatient Rehab Department for 5 years now. She graduated from University of Miami with a doctorate in physical therapy. Prior to joining Phoenix Children's in 2018, she worked for a community-based outpatient clinic. She's an approved Duchenne muscular dystrophy certified physical therapist through Cure Duchenne. And she's found a passion for treating children with chronic pain, complex regional pain syndrome, and hypermobility. Her continuing education includes topics on pain neuroscience and the American Physical Therapy Association with Adrienne Liu, therapist. So without further ado, I will introduce our team and they will tell us about the WRAPP program. Yeah, okay.
Good morning. Thank you for being here. We are very happy to present this program. We have been working on it for 2 years, and we're gonna do is a work of love for us. And we're gonna do it in the same way that we do our program, the three of us together. So we don't have any conflict of interests. Our objectives are to show what are the national resources for chronic pain, explain WRAPP, and show how you guys can refer the patients to us. So why we developed this program, right? First, we saw a need through the years that we have been working in pain. We're going to talk more about the burden of chronic pain in the next slide. But I can tell you, besides the burden that Dr. Zakaryan is going to explain more, we saw in the valley, at least in Arizona, we know the long distances for all the treatments. Our patients need at least 2 treatments as a minimum. If you just imagine that if they need 1 treatment a day, maybe 2 or 3 days a week, that is an hour for the treatment, an hour to drive, that is at least 3 to 4 hours for the patients to be away from the school, for the parents to be away from their work. So having a piecemeal approach is something that it was cumbersome for the families. They never finish all the therapies that they need to finish, or at least was the minimum of patients who did that. So we wanted to find a way to present something that was easier for the patients and the parents, and also to having better results for them. And we also were looking into what other programs we have. We found that there is no other programs in the state of Arizona for pediatric rehabilitation. Dr. Zakaryan?
All right.
So there's a lot of studies that are suggesting that at least 1 in 4 kids will deal with chronic pain during their kind of childhood and adolescence. So of course, being that pain that lasts longer than 3 months. Apologies for the error there. And a lot of the work is demonstrating that there's a huge healthcare utilization cost. Anywhere, kind of depending on the data you look at, from 12 to 20, almost $20 billion each year annually of these folks. And I think all of us are going to be living and seeing it, where they come to the emergency room, they get all their workups, their EEGs, their EMGs, their, colonoscopies and EGDs and all this kind of stuff. And so we can see where the healthcare system set them up for this. And so we wanted to find a way to help decrease some of that healthcare utilization and increase their functioning. And so what we were seeing, kind of just getting like general estimates, is that in Arizona, there's going to be like over 7 million people in the state. The PEDS population under 18 was about 22%. So that kind of gets down to the a little over 1.5 million. And then the kind of, if we think about 1 in 4, 25% having chronic pain at some point, that's going to be about the 400,000. And then if we think about Phoenix, the greater Phoenix area in general, that's going to be about 5 million, about 22% of that being the like 1,100,000, and then the kind of 270,000 or so, that's going to be the 25% of that. So that's a lot of kids, even though it looks like it gets smaller and smaller, of course, to be able to be the one like pediatric multidisciplinary pain program to try to treat them. So we were kind of thinking about what are ways that we can kind of diversify the modalities that we provide to make it a better care for these patients and families. And then one of, it's not only cost in like monetary ways, but also things like losing school functioning for kids and teens. That's their job, right? And so they are losing out on the social development, on their educational development, not to mention with the pandemic, of course. So what some of the studies were showing is that kids with chronic pain, not surprisingly, are reporting high levels of absenteeism from school, ranging from that like 6% to up to 34%, depending on the studies that you look at. A different meta-analysis recently from 2021 was showing that in the past 2 months, they were missing almost 14 days, almost 2 weeks, well, even more than 2 weeks of like the school weeks of school. And the most patients that were, or the most type of pain was this kind of headache, migraine kind of pain for about almost 50% of those kids. And then the average duration since the pain had begun was almost getting into 3 years, over 2.5 years. Some of the things that they were looking at to see like what could predict these kind of factors beyond just like missing school from before, in case those were like kids who maybe were bullied or who were maybe having a learning disability or something like that. They were definitely seeing like medication use, pain intensity. So I guess I should say pain medication use, to be specific. The pain intensity level that they reported, being a little bit older as an age of an adolescence, which probably means that they were also living with the pain longer. And then school stress, and school stress being more about like getting up early and having to deal with like being behind in school. And then, so of course our kids, live in, maybe I'll just press this button. Oh, there we go. All right. Thanks, Dr. Hartley. Then it's not only the kids, but the parents too, right? They don't live on an island. And so there's a continual economic burden for these families. And so across a few different studies, it was showing that parents were losing work in just saying like 65% of the parents who were working out of that kind of group were reporting that they were missing work. And that ranged between like 3 to almost 6 days. But then even more, it was that one of the studies was showing how their productivity loss was accounting for the 22% of like their family's loss of like cost and stuff in the year. And so this is a big deal, not only for the healthcare system, not only for kids, but also of course for their parents and families too. So it's something that we have to try to find new ways maybe, or new ways within our system to try to address it.
So the next step for us was to see what is out there. We look for local and out-of-the-state programs. And we found that at least when we started the program in 2020, there were 12 programs in the whole country as an outpatient. I'm not talking about the inpatient. It's a similar number, but that is not our topic today. At this moment in 2022, there are 17 programs. So that means if there is an increase in the programs, even during COVID, that what it shows that they also see the need that we are seeing here. Most of these programs are daily programs in range between 3 to 4 days. Some of the programs, there's one that only CRPS. Most of the programs are in general for pain and last, like I said, 3 to 4 days to up to 3 weeks. So what do we do next? How can we planify? We have to find first what are our resources. We have a pain physician, we have psychology, we have physical therapy, and we have two very good friends of ours, RDOs who do OMT, Dr. Kramer and Dr. Bowman. Thank you so much, because they were kind enough to finish their day of work and come afterwards to help us to build this program. Thank you one more time. So what are our limitations now? So we have a limited number of personnel. We are seeing like 80% of the time right here. We have 4 different locations in the valley. We don't have those locations every day. So having a daily program, it wasn't an option for us. And also we have issues with insurance for physical therapy. What is the maximum number of PTs that we can get for our patients? So those are the reasons that we were thinking, and then we come up with our program. This is our program, is a weekly rehabilitation and pain program. We decided to make it 8 weeks program, 1 day a week. Usually is one afternoon, because guess what? Teenagers don't like to wake up early in the morning and they're gonna be late anyway. So make it in the afternoon. We did it for 8 weeks because it was we were thinking what is a good number of time that they can commit, one, and second, what is the better utilization of the physical therapy that we have. Most of the insurance, they approve for 12 visits. So we did 8 weeks, and in the first 4 weeks, they have 2 PT appointments. It's always the same day. It's a Monday in one place and a Tuesday in a different place. We have 3 patients per cycle. We don't have room to have more patients because it's a full afternoon from 1 to 4, sometimes to 5 if they have OMD. They have the same schedule because what we are trying to show them is some degree of a structure that most of our patients don't have. So you can see on the side how we go. It's again, it's kind of a merry-go-round, always in the same way. Is PT, psychology, and pain. In my case, I manage medication, but mostly I do therapies like acupuncture. We try to stay away from medications as much as we can. If I see the need, we're going to start medication, but the idea is to go back to be a functional person and try to decrease everything extra that is not your own body healing you. So each person has 1 hour, PT, pain psychology, like I mentioned myself. And every 3 weeks, we have OMT. We would love to have it every week, but we have 1 provider per location, and then they have to be 1 hour for them. So it's ended up being 1, 2, 3, 1, 2, 3, 1, 2, 3 for our patients. Because it's a short program, it's only 8 weeks, they need to be committed to what they do. And if they are missing 2 or more appointments, there is no reason to do it. You're already missing 20% of the program, and they know this upfront, and there is no reduce either. So they need to know for sure that they want to do it. After we finish the day, we all meet at the end of each session to know how the patients did, what are we going to plan for the next session for each patient, and we try to be congruent in what we are teaching at the same time. And also we try to be congruent in the language that we use, because many times for us, 2 words are the same or they're similar. For teenagers, it's completely different. They hear only the word and they think that we're saying something different. Do you have any examples of that?
I mean, things, or even just like sayings, like, we like to say like motion is lotion, or things about, I'm trying to think of what else, like, just thinking about functioning and making sure to, again, kind of keep that consistency, keep that kind of structure, because again, one of our like frameworks is thinking about like stress and trauma and polyvagal theory, and what do we know is that if things are always changing, our nervous system is never regulating. So if we can kind of provide that structure and consistency and we can kind of bring that down, I think, see more success that way too.
Not even with what we do to them, but what we said to them.
Mhm.
And in that way, can we start to sync with the patients? And you can see at the end of the 8 weeks, they kind of can repeat the same thing that we are saying to them. So what are our admission criteria? We look at the clinic and what we see more often. Chronic musculoskeletal pain is the most often. And we try to tackle one population first, otherwise it's going to be just so scattered. So we try to hone into chronic musculoskeletal pain, body pain first, develop protocols for that, see how is that working. Then with the time we added headaches, same, we added a protocol for headaches too. Then chest wall pain. We are open to all patients, and we have one CRPS patient that was with us at the beginning. We just need to see what are the needs and where is the patient at in the evaluation. One of the most important things for us is patient readiness, and we learn that by doing it and by having some mistakes. Yes, it is what it is.
Yeah.
I'm just gonna be honest. At the beginning, we listen to the patient and we listen to the parents. They are the advocates. They say, no, my child is ready, she's gonna be ready. And we believe that. So we treated what the parent was saying instead of looking at the patient. And other times when we saw one of our patients, we said, well, we can help them. We didn't realize that the patients weren't ready at that moment. Because guess what? Teenagers, they like to say whatever we want to hear, so we get out of their case. And we learned that. We even try to do a score to try to find a very clinical way to say that the patient was ready. They lie in the score. They show something, but the actions are different. So what we learn is after doing this for a certain time and doing pain medicine for longer time, we try to get to a consensus after we have an evaluation that we usually do the three of us to see if we consider that the patient is ready for once. And second, most of the time we need to prepare the patient and we ask them to do something. We ask them to start therapies. Maybe they start PT, maybe they start psychology, maybe they start other therapies. And then we follow up with them. And if they continue to follow, that shows commitment. And if they show that commitment, we present them the program when we consider that they are ready for it.
Like the one caveat I get, or the one additional thing I should say, is that also it's like the kind of typical things you might expect, like people who are not actively suicidal, for my case, or like, people who don't have super detrimental OCD or anxiety or depression. So that, because that's going to like not be able to have them engage for like the program. So we kind of want to help them get that first. And again, that's part of that showing commitment. And then we can kind of engage them later.
So what we measure, we have a short-term goals in 8 weeks is one test in week 1, one test at week 8. And we have long-term goals. The short-term, we have one that is specifically oriented to the patient. It can be going to the theater, doing the rehearsals, going back to choir, something that is tangible for them, something that is the carrot for them to continue doing it. Then physical therapy has functional skills, and you can see them. Functional, that is proper to the patient. Then you have lower extremity, upper extremity, headache disability. And at the end, after a year and something, we realize that all those are self-reported. What happens if the patient is still in the mode that I cannot do things? Then we need to show them that they can do something. We need one objective one. And that is why we added a 6-minute walking test for endurance, because most of our patients, their endurance is lower than the average. And we realized, by the way, that this 6-minute walking test, they are at least 100 meters below average for age. Right? That is our best patient, is 100 below. Yeah. So for long-term goals is a year or two. What they want to do, I'm gonna go back to soccer, I'm gonna go back to rollerblading, I'm gonna go back to volleyball, or to go back to school.
And then in psychology, what we're kind of doing similar, again, it's pre-post kind of WRAPP participation. And so it's basically 3 questionnaires, self-reported. So pain catastrophizing, as you can see, this functional disability inventory, kind of understanding. Well, pain catastrophizing is like your worries about your pain and how kind of upset or like anxious you can get about it. Functional disability is like thinking about like walking upstairs, walking a football field, running a football field, getting to sleep, staying at school all day. Those are some of the kind of items. And then this promise is like an NIH-based questionnaire kind of things that they had developed to be free and also to be able to be consistent across different kind of populations. And so they look at within the past week, and then these are the different subscales, checking on their mobility, anxiety, depression, fatigue, their peer interactions and relationships, pain interference, and pain intensity. And that's kind of just to capture at the beginning. And I think we are always in the progress of trying to figure out what else maybe would we want to add to capture things that are changeable in those 8 weeks. But this has given us a nice start to go forward.
So that is what the program is. Now, what is not? This is a free polling guide. So we are before that point. The free polling one, that is an inpatient rehab 1 to 3 weeks intensive, where the providers have to pull the patient out of bed, literally, and work with them. We infuse them the energy. This outpatient is an outpatient when somebody's motivated. We show them the way, we give them the tools, and we show them that they can do something. But they need that initial motivation. So it's a few steps before free polling. Not there, but before.
Hi, good morning. So we're going to be talking about physical therapy, the one of the 3 parts of this. I want to start off by saying that this multidisciplinary approach has made our PT's life. So my coworker who I work, my partner in crime with, Alexa, I'm going to be referring to her as well during this. She's not here today, but we have seen such a success with our patients in PT with this multidisciplinary approach. Like Dr. Genovese and Dr. Zakaryan have been saying, it's all 3 pieces that have come together that really help these patients. Physical therapy alone, it's not enough. And we've seen that early on before we started this clinic, before we started WRAPP, we would have patients just drop off at 6 weeks. And Alexa and I were so confused as to why this was happening. And we need that psychology and that pain part of this, and the acupuncture and the OMT. I cannot say enough good things about the OMT. Our patients thrive off of that. So with that, the goal of physical therapy is to restore independent function, mobility, and to address patient goals. And Alexa and I have had to really shift our mindset, because in PT school, you kind of are taking these patients from 0 to 60, right? Like your bicep tear, your general orthopedic. This is not the population for that. This is a graded progression, constant communication to decrease the anxiety of what's coming. Because a lot of our patients that walk into PT have anxiety about movement because they've gone to like the PT 360 place who didn't really know how to treat pain, because they'll just put on the bike, give them 3 sets of 12 of hamstring curls and call it a day. And it pushes these patients past their limits and makes them go into even more pain because their nervous system is so sensitive. And so we've had to really change our mindset around what is a functional goal for these patients. We have some patients who will come into WRAPP and they can't even do a 30-minute target run with their parents or with their friends, which is why we do the 6-minute walk test to grade their endurance. They have to sit down within going into 5 minutes of standing at school. They're constantly changing positions at school. Some of our patients have had to drop out of school, again, with Dr. Zakaryan touched on with the school attendance. I've had patients tell me that they've gone to 8 days of school in 1 semester because they're in such pain and their nervous system can't handle that load of going into school, carrying a backpack, navigating hallways, stairs, sitting in desks at a high school. It's a lot. It's a burden. And we've had to really change our mindset because we've taken for granted the function that we have. So we set the goals using the scales that we've talked about before 6-minute walk test, the LEFS, upper extremity scale, the modified oswestry, low back pain, the headache disability, and the dizziness handicap inventory. So that's how we set our goals. And so like on to the next point, we have to work on avoiding extremes. Some of our patients are very, I want to say in the best nice way, type A. They want to like achieve, but they can't at this point in time because they're in so much pain. So we have to really educate them on, we're trying to find a middle ground here. We don't want you to overdo it, but we don't also want you to underdo it. So we have to educate on the impacts of the body system and of what the pain is doing on the body systems and on function. We also have to educate them on what sedentary behavior does to them as well. So you have to find this fine line with them of, we can't just sit there and not do anything and stay in bed all day, but we can't also overdo it, and we're not going to go run a marathon in 2 weeks. There's a fine line you have to find with these patients. So then that goes into the graded progression. I'm going to kind of talk about that too today. We just don't go 0 to 60. We go 0 to 5 to 7 to 9 to 15, depending on how they want to do it, and how their body responds. We're constantly checking in with patients and parents, seeing what the patient is saying, but also seeing what the parents are seeing at home as well, because we don't get to go home with them. So it's really nice when we have other people that kind of tell us what's going on behind the scenes. We have to educate on, we're unlearning no pain, no pain. If I don't do anything, I'm not in pain. Well, can't go through life not doing anything. We need you guys to get up and do something. I'm also unlearning no pain, no gain. We're not here to like go all out and go lift 150 pounds and then be in so much pain the next day. That's not what we're here for. We're here to find a happy medium. So part of PT, a lot of PT actually with this pain, chronic pain population, is educating on pain neuroscience, or what it's called PNE, and the impact of the nervous system on the body as a whole. So we talk about the nervous system using kind of like analogies, because it's kind of hard as a teenager to wrap your mind about this invisible structure in your body that's kind of running everything. And especially if they haven't been through like anatomy and physiology in high school, it's kind of a shock when you start talking about the nervous system with these patients. So we talk about the stress that's going on in the body. So we use fight or flight, the fight or flight system, kind of talk about that so that they can understand what the stress that's occurring internally. We talk about body sensitivity, which is how the nervous system and the brain become sensitive to the environment around them because they've been in pain for so long. We also talk about the nervous system as the body's alarm system. So pain is an education, right? Because I don't want to go around and touching hot stoves all day. I'm going to get a burn on my hand and get some tissue. It's not going to be tissue damage. It's not going to be good, right? Pain's an education tool. So we try to tell them that the pain is telling you that your body is going under too much stress and we need to dampen it down. And that's what PT is here for. So we are constantly providing education and encouragement that they can do this. And we're going to show them how through incremental steps. Hurt does not equal harm. A lot of our patients are hurting and they think it's a tissue or a muscle that's hurting. And that can be, but also it can also just be how the brain is perceiving the environment. So we talk about that too. We want you with PT, right? We talked about we don't want to be overdoing it. We also don't want to be underdoing it. So we talk about sore, but safe. We want you working out to some degree. We don't want to push you over the edge. We don't want to underdo it too. So they're going to be a little sore because when you move your body and you're creating muscle strength, you're going to get a little sore, but it's okay. We encourage them. It's okay. It's not pushing you into that extreme pain that you're feeling. It's the good type of sore that we're feeling. So we try to educate them on how their body's feeling. So pain versus sore. So that's also what we do in PT.
Some safety.
Yes, and safety, because again, I talked about the PT 360, how they'll go to these outpatient clinics who just push them beyond their limits. So they're scared coming to us, very scared. I've had a couple patients, they always like to tell me their PT horror stories. And so part of my job is encouraging them that Alexa and I, we approach this PT very different. And I'm going to show you a couple of the first week exercises and some of the responses I've gotten from patients. This is a very different PT approach. This is not your walking into a outpatient clinic and I'm gonna give them 3 sets of 10 for the next 3 weeks, and then we're gonna be moving to the weight room. This is not what this is at all. So some of the PT progressions that Alexa and I and our co-workers here at main campus have done is hypermobility, chronic musculoskeletal pain, and fibromyalgia. We have like kind of PT frameworks for that. Everything is individualized, but we have frameworks that takes them through this progression over the course of 12 weeks. We have a PT program for headaches, and we also have one for chest wall pain, and we have abdominal pain that's in progression. So I've been talking about this progression, and so what it's called graded exercise therapy, or the acronym GET. And it's an intervention technique that utilizes physical activity as the principal treatment method for addressing the symptoms of chronic fatigue syndrome. It promotes engagement in a program of physical activity that starts slowly and gradually and increases over time. So what does that exactly mean? That's a bunch of really smart words. So this is our first week this is the chronic pain kind of framework of what we work. This is the first 2 weeks. I didn't put all 12 because that would take up tons of slides. And this is just 2 exercises of like 6. We try to not overwhelm them. Alexa and I go in and tell them, we like to be upfront with you guys. This is your homework. This is what we expect of you. There's no surprises. There's no shock. There's no shame. What we want to really avoid is shame, because I think these patients internally, what we've seen, they really put a lot of pressure on themselves, and they know that they're in chronic pain. They want to do something about it. They can't. They need help. They need the structure. And so this provides them a structure of what they can do that's safe for their body, that's going to help them to get them out of that chronic pain just a little bit more. So we start with mat. We start a very low level mat. I actually had a patient roll his eyes at me yesterday because I showed him week 1, and literally the biggest eye roll. I mean, you could hear it probably across the PT gym. It was very loud. I think his dad got a little embarrassed too. But it's so important to start with on a low level mat, because again, I talk about, we don't want to go 0 to 60. If I start you standing up and then week 3, you're telling me that you're in even more pain and can't get out of bed, I have done my job wrong, because we need to start with a trunk, a good stable base of support. So then when we hit week 6, when we're off the mat, you can stand with minimal pain. You know how to bend your knees in a nice strong bend to engage your glutes, your pelvic floor, your core, your deep core, your transverse abdominis. That's the whole point, is just re-engage these muscles and get them the mind-body connection again and get them out of that pain. So we work heavily for the first 2 weeks on just abdominal bracing and glute activation, and isometrically. There's a lot of studies going around right now, because post-COVID world and sedentary behavior, we don't know how to isolate our glutes anymore. Our glutes are the main powerhouse. Sit to stands, just getting out of your chair, you're going to be using your glutes. You're going to be using your transverse abdominis. If you want a term for it, it's called dead butt syndrome. Stanford and I think Harvard uses that term. It's not my term, it's Harvard's term. So we're literally untraining their butts to work. It's an isolated contraction of the glutes, and it's really hard. If you go home tonight, please try to isolate your glutes without co-contracting your hamstrings. So that's the first 2 weeks of this. It's very hard. And you look at these and you're like, I'm just on a mat, I'm not doing anything. It's a lot of work. So the first 2 weeks are mats. We move to higher reps, lower sets sometimes over the next probably like 4 weeks. Then probably weeks 6 through 12, we're doing standing. We move from functional exercise to functional strengthening exercises. We'll sometimes even refer to sports. Our patients who want to return to sport will refer to sports PT across the street. We're really, after we're finished, that's way in advance, but that's like the progression that we're going very slow to, we can get them where they need to go.
I was just going to say some of the language that we kind of repeat is that kind of thinking about even from the beginning of the intake is like that PT is going to be helping you with stability first, then stamina, and then strengthening.
Yes.
And so I think if they kind of hear that, then it's like something that we know that you're not going to be going out running on the treadmill for 30 minutes. You have to start with these simple things. And it's like kind of this kind of psychoeducation that we're giving from the beginning.
Yes. We start on the recumbent bike. Aerobic activity is so important. It improves your mood, improves sleep, which is great for teenagers, lowers pain, uses your indigenous system to work with endorphins, helps with, I said sleep, Also works with decreased stress and helps with soreness and fatigue.
And one more, there is a study done with 2,000 patients. They show that if you exercise, you increase androgens, and those are the ones that decreases pain too,
Yes,
not only endorphins.
PT
Yeah.
is so important with pain. So important. So it's a lot of education, a lot of encouragement, a lot of going over. Please don't overdo it. Please trust the system. We're gonna go slow. It's gonna be safe and you're gonna be fine. Maybe a little sore, but it's good sore. So this was the first 2 weeks of the chronic pain. Next 2 weeks. So this is an example of chronic headaches, of what we would do for a chronic headache. If you've ever seen a patient with chronic headaches, their posture is very rounded, or what the research is calling a text neck. This younger generation that's coming up is getting the text neck, is what we're calling it. That forward neck posture, rounded shoulders, very curled up here. So we start on the mat working on the big muscles that control the posterior trunk and the posterior chain. So glutes, hamstrings, and everything in the trunk, lats, rhomboids, big muscle groups to help them get up to here, decrease the tension that's all up here to try to help with some of the headache intensity that they're getting. Week 2, we go into prone positioning and get with the gravity, with gravity working on them. So again, very slow, incremental. I see some of you guys adjusting right now. Incremental progression. I know, right? Okay, we're good. Incremental progression. And then what our goal is at the end of all this with the headache and the chronic pain PT guidelines, is to get to the 20 to 30 minutes of doing aerobic activity. We let them pick and have at least some control over what aerobic activity that they want to do. Not everybody likes to walk. Not everybody likes to run. That's fine. Go swim. It's Arizona. Go bike. So we like to give them some like autonomy in that, but we're trying to push that aerobic activity. We also end PT. Alexa and I had a really good opportunity in 2020 to create a comprehensive program. And so we hand you a guide at the end of the 12 weeks that goes over everything. And so that they're not just left off the edge of like, what now? They get like about 3 to 5 pages of homework that they can pick and choose throughout the week. So that's how we wrap up PT. And those are my resources that we use.
All right. So we'll go through this pretty quickly, but like kind of just to kind of put into visuals, like what we're kind of talking about is this hurt versus harm kind of cycle. So a lot of our patients are just having the pain happen. They have more painful experiences. They catastrophize. They're afraid of moving and doing PT, thus more avoidance. And so they're not able to use their body as much. They're not using it. They get depressed and sad. And then this like is a vicious kind of cycle. And so how can we break that cycle? And that's what WRAPP and many of our kind of treatments are trying to do, so that even though we have pain, we try to lower the fear around it. We try to approach what we can do, and then we can get into recovery. So that's like a big piece of it. And so that's what also with pain psychology, what we're trying to do. Again, we kind of start with the basics that we know with behavioral stuff. That's okay. Start with easy if we can get in distraction, and that's the entree point. Bring diaphragmatic breathing also works well. That first week where we kind of can teach it maybe together, and we talk about transverse abdominis, and then we're kind of, that's one of the kind of repeat things that they get to hear from both sides. Progressive muscle relaxation as possible, depending on, what part of the body hurts or not, but that can be something that helps them. Obviously, like also bringing in sleep hygiene, because sleep is often super duper affected for our patients who have chronic pain and who are then out of school and then don't have a reason to get up in the morning, and then it just is kind of starts to spiral. So that can be something that we work on. Then there's the different multisensorial kind of 5 senses strategies, and so that's going to be things like the grounding. So that's like what we would call like nickname 5, 4, 3, 2, 1. I bring in mindfulness. Of course, there's a bazillion ways of doing mindfulness. Our version is like kind of using a mindful object, because for kids and teens, being able to touch something in the moment is probably going to help them more. That could be a favorite food, a favorite drink, or even like a little anything. And if we had more time, I might have done a little exercise for us here, but I even kind of say like it can be a mundane thing like chopstick, right? But the way that if we can kind of turn on our curiosity, that's like where we usually see more change. And the way to kind of bring in that awareness, whether it's body awareness like PT or our other kind of sensory awareness, is like maybe, to be silly and funny and thinking about being like an alien who's never been to Earth before. So now everything is new and I want to see all the details about everything, or being like a very good doctor or scientist. And I'm going to take all the notes down for all the different senses, and like kind of bringing that awareness to them. So that can be something that can help them out. And then guided imagery with or without aromatherapy, because that kind of brings in another kind of sense. And I think it can be funny or silly or like hands-on, which helps the patients and teens. And then clinical hypnosis, myself and our other pain psychologists have been going to some trainings for clinical hypnosis, so we can bring that in if parents or patients would like that. There's a lot of overlap in all of these things, so we kind of acknowledge that as well. And then of course on the cognitive piece, the quintessential CBT kind of based, cognitive behavioral therapy based things is the thought record and bringing in that connection between our thoughts, emotions, and actions. And how can we reframe? Again, I like to kind of say like being realistically positive, because I'm not going to tell you like, hey girl, like, don't worry about it. It's no big deal. You're going to be fine. Because that's not being honest, right? That's not being authentic. We have to say like, this has been so hard for you for a really, really long time. And there's the team approach to slowly and surely with time, get better and better. And so that's a big another message that we kind of share. So parenting is another big piece of it. So kind of these kind of positive reinforcement plans are gold stars. That's a huge thing because we know that that's what changes behaviors. And so that's a big one. And then just language, helping the teens and like adolescents with their assertive communication, helping parents with reflective listening and specific wording to avoid things like, I'm so sorry, I can't help you. I'm so sorry that you have pain, or like, oh my God, are you okay? Or like, what's your pain level now? We want to shift the language away from pain and more towards functioning, because that can still show care, but it's putting it to the thing that we want to strengthen and what we want to reinforce. What are you up to today? What do you want to do today? That sounds really hard. In a few minutes, what can we do next? Something that again validates, because that is going to then get into this big thing about with self-efficacy. Because in the healthcare system, patients have been invalidated and parents have been invalidated over and over and over again. Just the way that it's set up. Your labs are fine. Your imaging is fine. It's unremarkable. Like, oh, you should be grateful, or like you should be happy. And it's like, these people don't get it. And it's not for the fault of anyone else, because as you guys already know, like I think some of the stats patients or other people say is like, there's like a half day of pain education in medical school, and like, veterinary schools give like more pain education. And so it's like just a systemic problem. And so it's how can we now kind of be helping before we change those kind of systemic problems in our care. And so this is just like how parents can be like, just leave me alone, to hopefully doing more reflective listening. And this is just, again, we won't go too much into it, but just a mock schedule of the different kind of strategies that we would do and how we would kind of get through the 8 weeks. All right.
So I don't know if you can see through those slides, but I can tell you that we work every week to try to coordinate not only the skeleton of our program, but individualize for each patient. It's a lot of working together after hours to get the best for our patients. So this is briefly the data that we have so far from July 2020 to March 2023. We have 44 patients total. Of those, 4 dropped, and 40, that is a 9%. 2 for acute hospital admissions. They really wanted to continue the program, but has something acute that happens. 1 didn't think the program was good for her after the first visit. That hurts us deeply, but we continue. And 1 got upset because the front desk sent her to a different location across the street, and that was it for her. So perhaps she wasn't ready. These are the ages that you see from 11 to 19, mostly between 12, 14, and 16. I might say that 12 we have triplets, so it's a little off. But between 14 and 18, I will say that is the majority of the patients. For the diagnosis, no surprise, musculoskeletal pain is the one that we are going to see more often. Then is headaches, chest pain, and 1 CRPS. Of the musculoskeletal pain, what other diagnosis do they have? They all have muscular pain, but the majority of them have hypermobility as a secondary diagnosis. Benign generalized hypermobility. There are others that have localized hypermobility. I'm not including those patients in this. Then you have pain post viral infection, different type of, it can be, I think we have 2 or 3 for COVID, 1 or 2 for mononucleosis, I don't remember exactly, but it was clearly marked after a viral infection. Then fibromyalgia without hypermobility, then the other diagnosis that we have. 2 mast cells also that are very challenging to treat.
So this is where the prior mental health diagnosis, what they came with was for the 26 patients out of the 44 who were presenting with that anxiety, not surprisingly, for the majority of them, depression. Also, we can kind of see that co-occurring. And then eating disorder, again, kind of for a white teenage female. So kind of would be a part of what we would expect to see. But the caveat is that once they got into the clinic, they are often conceptualized instead either with a separate adjustment disorder. So that's like kind of a part of the stress and trauma related disorders in the diagnostic manual for psychology, or it's added to their diagnosis. So it's like the depression, anxiety maybe is more captured by adjusting and all this stress and trauma, which again, kind of underscores our kind of framework with the polyvagal theory and like thinking about, at least for me, like the autonomic nervous system and how that's a big kind of motto that we kind of are helping educate them on.
So these are all our patients, and these are going to be the goals that they reached at. 44 patients, total 4 drops. So we have 40 of those 40. We found pre and post data on thank you, I can read. And the other 17, what we used was the specific goals, the short-term goals that the patients for themselves. So of this, you have the majority of the patients, 65% achieved the goal, the rest partially achieved, and only 1 patient did not achieve any goal. This was an 11 years old post-cancer, post-stem cell transplant survivor. I think the patient was young first, and second, have a chronic diagnosis where they surrender to providers, right? When you have cancer, you are in bed, you don't do much for many years, and you just obey. This is different when you have in our program, this mindset should be the patient, I want to do things, and we're going to help you. And I think he wasn't ready for that. For the patient-specific functional scale, you can see the results there. We have the maximum that you can reach is 10/10, and that you pick what the patient wants to do, and they give you a grade score for that. So most of the patients improve. You can see that they improve from 14% to 220 of the baseline of the initial assessment. There's only 1 that went negative. I might say for this patient, that was a bad day for this patient. I know her and I keep treating her. She's better than she was. It's just difficult for her to see it, but I have to show the results that we take. For the upper extremity, most of them, they improve. For the lower extremity, also they improve. You can see most of them, they were already in a good score with exception of 2 of them. For headaches, we have 5 patients with headaches. Of those, they have this, when we use the headache disability index, it should be down. That is what we want. 1 patient went up, the others went down. The maximum was 14%. I'm going to say something. For the headaches, I review each of these patients individually, and what the headaches disability index is what they report. They report they're the same or they are worse, but if you use the functional scale, they are always better. So I think what is happening, they're functioning better, they just cannot see it because they haven't been helped for such a long time. The only thing that they know is that nothing works. And 8 weeks perhaps is not enough time for them, or we are picking the patients that are too far out in the disability. So we need perhaps 1 or 2 medications before, trial and error before. For the 6-minute walking test, we have all the patients improved with the exception of 1. That 1 patient, I must say, was a 12 years old who had 2 abdominal surgeries in 2 weeks, who was in the hospital in the middle of WRAPP and decided to go back to it. So I take it a minus 2.5%. I think it's pretty good after 2 abdominal surgeries. And this is what we do it. She's one of our patients. And she was in bed when we got her. For wanting to get better. Why? So this was a year after the program. And what she wanted is to get better. The only thing that she wanted is to go back to Royal Grade, and there she is.
All right. So some of the things what our parents and what our patients and parents say. So they were saying much more in-depth treatment than coming every so often. So that kind of bundled care. Did WRAP help? Yes, absolutely. I could see a difference in the patient's physical and mental state by week 4. This has been a positive and uplifting experience. So it's like a lot about giving hope is what we're doing for after all these years or months of like having wall after wall for patients and families. After 2 years, XX is finally playing soccer again at a very competitive level. Thank you for helping her achieve her goals. It pushed me harder and I had to step out of my comfort zone. Yes, my pain has decreased and I have noticed a physical and mental improvement. Did WRAP help? Yes, I do. I do my stuff by giving, it gave me the tools that help to deal with my problems. I have a lot of them, so good job. What did you like the most? All of it. Appreciated the whole body-centered approach for the parent. What did you like most? That it was focused and bundled, felt like doctors were working together on a comprehensive dynamic plan. Amazing overall. We are really forever grateful to have been a part of the program, and we need more programs like this.
So, last slide, how to order. This is how you do it. Outpatient order set, pain medicine, consult complex MDC, put my name because we are the one who evaluate the patient for the program. That's it. You can always send an SCM or an email to us. Happy to answer.
And the reason you can put, it's kind of cut off, but evaluate for a WRAP or something like that. Oh, yeah.
So that's it.
Well, sure. I mean, so it's like how, it takes a village to raise a child. And so our village to say thank you to, we have ourselves, but like our wonderful physical therapists, Rachelle, Alexa, and next, Erica, Laura, then our wonderful DOs, Dr. Kramer and Dr. Bowman, and then Deanna Smith, who's here, claps for Deanna, our nurse coordinator, Desiree, yeah.
Yes.
Desiree, our ops and now practice manager, and then our patient access representatives, Samantha and Jose. We couldn't do it without them.
No, not at all. Thank you, guys.
Such an impressive program, and I'm so unaware of something that's happening. So
We did it on purpose because we wanted to start silently until we are on the kinks.
I think that's very focused on the goals of the patient, but during the access sequence, maybe the survey, how much of a goal do the parents like they survey?
Yeah, so the surveys right now are only for the patients for this, but now we have incorporated more parent and patient surveys at the clinic level. So they should be having those completed already before they come to WRAP. So that'll even help us more. And I have basically, most of the time I have parents with me almost at every visit anyway, because it is so much about parenting. And, spoiler alert is that hopefully also with bringing comfortability, the workshop, it's a day-long workshop for adolescents and their parents at the same time concurrently. And that's where we teach a lot about that pain neuroscience and pain education and how to validate and reflectively listen and minimize some of that accommodating parenting or over solicitous parenting or the like suck it up and deal with it parenting, because we have to find that balance. Again, so much of it is about balance and helping co-regulate, because that's the only way that we can really get into our maximum rest and digest, is that if our parents are regulated, then we would be regulated. If our environment is regulated and stable and consistent, like a weekly program that you're going to, then you can also help decrease that kind of sensitivity of your nervous system.
And yeah, the other thing is that we are working more and more with the Center of Resilience. And that is when the patients qualify, and most of our patients qualify for that. We work with them and we try to send to them first, so they have some degree of baseline already, so we can work on that.
Yeah.
while they're admitted, feel their candidates, or do we have to just schedule out?
The inpatient environment is such a different environment for the patient. We were gonna do it outpatient. When they have that extra stress of being inpatient away from them because they look completely different. Yeah.
Will you have the information that we can have it out of office? At least the same time, patients will be grateful with really something like this, but I know a big barrier in the front end is something that is more of a tool. And I feel like it's struggle maybe fix, but it's lost all the up and down.
I would say if you refer to the pain clinic and say to them, we want you to be evaluated, perhaps they can have all their tools to use or all their treatments to use, but don't mention the program from the beginning because we need to evaluate if they're ready or not. And sometimes we have one or two patients that somebody else mentioned the program and they were adamant that they wanted and they push, and those they usually don't end well because they're not ready.
And, kind of keep your eyes peeled that with comfortability, that might be a better thing that could be referred. We're still going to figure out the referral process, but that might be something that could be referred from inpatient. Yeah.
Curious about that. What are your thoughts on the future about patients who decide experience some experience that some other strategies on that program that you see or
Well, initially, we don't want to do that because we want to stress how important it is for them to do their best. But if there is anything that is a specific event that is completely different, out of their control, I think we will reevaluate the patient without any problem. But no, it's not a thing that, oh, I didn't finish the program, didn't improve, and now I want to redo it. Should be somebody who was successful before.
For PT with a relapse, we also won't just push you through to the next week, to the next progression. So we've had to reevaluate sometimes and be like, okay, we need to stay at week 2 and tweak some of the exercises, or we need to go back. We're at week 6. We need to go back to week 3 and build up from there. So we're constantly adjusting too with that.
And there are some patients that we finish the 8 weeks and we say, okay, I think this patient needs a few more weeks of PT to get to where they want to, or it needs a few more weeks with Dr. Zakaryan or with me. Because they usually ask also, is 8 weeks and bye? And say, no, we want to continue.
Yeah.
And we just slowly,
That's
not having your head all the time.
That's another kind of analogy that we say is that WRAP is not going to cure your pain, right? It's the kind of thinking that if you are at stair 1 or 2, we're not going to get to stair 10, but WRAP can hopefully be a synergy or a combination that can get you to 4, 5, 6. And so we're getting you a little bit of a jump start, but it's going to have to keep on going afterwards. So that's another theme that we make sure we say from the beginning.
Yeah, we tell them that it's a good jump start, but it's not the end. It's just the beginning.
And if any other questions, please feel free to find us in the directory and email us. We're very passionate about what we're doing, and we want to help serve our patients and families better and better.
And I'm going to add one more thing. We did all this without asking for 1 cent extra. No one new provider, no one new thing, nothing. With everything that we have already, we just reorganize. Thank you, guys.
Okay, well, thank you all for a very fascinating presentation. We're at 8:30, so it's time to end. And just